So thank you all so much for joining us today. My name is Rebecca Cunningham, and I am just absolutely thrilled to have the opportunity to introduce everyone to the FACTS Consortium and kick off our panel today. I'm excited to welcome all of you who are not from Ann Arbor to Ann Arbor, as well as to, I think, about 60 or 80 people that we have live streaming as well online. We can get ourselves going today. We have a pretty hard stop at the end here, so we're going to manage our time along the way. The FACTS Consortium, I get to start to tell you a little bit about today is our launch of our FACTS Consortium more publicly, and I just can't be more excited about the opportunity for our group to come together and to do this work. And I wanted to take this chance to give you a little bit of background as to why we're doing this work and a little bit, just in a couple-minute overview of what it is that we're doing as a group together before I get to introduce our speakers who will be the main event for the day. As we think about firearm injury, and we'll hear more about this from Dr. Carter in a few minutes, in 2016, firearm injuries were the second leading cause of death among children altogether in our nation, accounting for 16% of deaths of all children. Yet in about 2009, 2010, and even the years leading up to that, many years we only had very little science to tell us what to do about this, some years as low as 33 total publications. And in 2014, when our group came together to start to think about working together as a consortium, there were really only about 12 very active, seasoned firearm researchers in the country. And few physicians, actually. So when we think about why that's important and why we needed a research consortium and why we needed to come together under this FACTS consortium to build capacity, we think taking the example and cue from other science public health issues that have been successful. We see if we take the example for motor vehicle crash as a great example. On the top left, this is a busy slide. On the very top left is the peak of motor vehicle crash deaths in our epidemiological history in about 1965. And then over the course of that time, we see the decreasing deaths from motor vehicle crash at the same time that we see a massive amount of investment that our nation made, both in science, creating the agency of NHTSA, passing a number of laws. And I'll remind you that during this entire time, we also have not decreased cars on the road, and we have not decreased the number of miles driven, but yet we have dramatically decreased the number of deaths by firearm injury. And this is a great model for us to think about our work from. And that model takes resources and funding. And when we think about some of the investment that came from that with motor vehicle crash, which is the MVC up there on the side, we see that millions and millions of dollars were invested, and many, many, many research grants were invested over even a 10-year time period to decrease the amount of deaths by motor vehicle crash. Meningitis, as a physician, I can tell you, is a very terrible disease, and it is something we certainly should be investing in. Over the same 10-year time period, the NIH, this is a cursory report of NIH reporter, had 75 grants on meningitis to help decrease the deaths, which were about 580 or so from meningitis over that 10-year time period. Firearm injuries, on the other hand, which killed over 27,000 children in our country, had 9 federally funded grants focused on decreasing the burden of injury among children. And so now here we are today. The NICHD, we are very grateful for the vision that they had to realize that we needed to rebuild the capacity in the field to create a research, jumpstart the field again from those 12 seasoned researchers that we had, jumpstart publications so that they are way more than 33 ever again in any future year, and created the FACTS Consortium, this R24 funded mechanism. And together with our FACTS Consortium, we bring together over 25 experts in the field, a mix of senior and junior investigators working to build a next generation of researchers to address this problem. Together, we will create a pediatric-specific agenda. We will fund core studies. We will establish a website, which I'll mention briefly, and build a pipeline of junior faculty researchers. We do this bringing together institutions all across, academics from institutions all across the country, north and south and east and west and more rural and less rural, to work together because we know we need everybody's perspectives. We do this with the guidance of a group of stakeholders that represent a broad perspective on firearm injury and firearm ownership, respecting the rights of our citizens to own firearms, with the underlying principle that we do not expect in our work to overall decrease the number of firearms in our country, that we expect that that's a fixed variable, and that there are other good public health methods that we can use to decrease the burden in the meantime of injury and death in the same way that we have with cars. So in this first, is it only 10 months, folks? I think in the first 10 months since our group has started gathering, we have been incredibly busy. We have formed work groups that include a surveillance work group, a primary and secondary prevention work group, an epidemiology work group, a data work group, I think I have them all in, and we have worked to survey the existing risk and protective factors. Thank you, Mark. We have worked to survey the literature and create a number of broad reviews, which should be published early in 2019. To update the field on exactly where we currently stand for the state of the science. We have worked to generate the content expertise to create a pediatric-specific firearm agenda. Any good pediatrician will tell you that children are not small adults. We need our own research agenda to address firearm injuries among children and how those may differ and how children may sit within a context of the family and the environment that they live in. And we have worked for the past year to do that with stakeholder input along the way. Today, thanks to Lainey Rupp, thank you, Lainey, we have launched our firearm website, our child firearm safety website, which is our FACS website, and I encourage you to go to this site. We are still filling out some of the pieces, but on this you can find details of our team, details of the work that we are doing, and also information about some of the underlying architecture, which we plan to have a repository and archive of much of the data that exists so far on firearm-related injuries to be available for researchers across the country to be able to access and download with the proper permissions, and also as an opportunity for all of you who may do future firearm research to upload your data to this as you develop it along the way, so that together as a field we may grow. Some of the other ambitious work that we have planned for the next 4 years, the group is already tired just listening to me think about it after the last year we've worked so hard. We have a number of pilot projects that we will, core projects that our group will work on. Part of the problem for our field is in order to have large, expansive research that could really change the field and change injury, one has to have pilot data and early work going, and there hasn't been enough funds in the field to have that happen so far. And so our group together will work to kick off some projects to help remobilize and energize the field. We have postdoctoral fellowships and internships and students joining us to help increase that pipeline of researchers. And on our website, we also will create curriculum both to inform practitioners as well as to inform other researchers in the field on the education and the body of science around firearm injury prevention, which is a body of science in the same way can be addressed as other fields of injury prevention. And with that, I thank you so much for your attention, and join me in my excitement of the launch of this, of our FACS Consortium, and I would like to introduce our expert panel for the day. And what I'm going to do is I'm going to introduce all of the faculty who will be speaking, who will then come up and give their slides, and then we will have time. We will reserve questions after in a panel format after. And I will say we have one of our last speaker, unfortunately, his plane got delayed some, and so we may have a little pitch hitting for that. But give me the pleasure first of introducing Dr. Carter, who will be our first speaker. Dr. Carter is an assistant professor and a board-certified emergency physician in our emergency department here. His research focuses on firearm injury prevention, specifically the development and implementation of an emergency department-based interventions to decrease substance use and firearm behaviors among high-risk populations. And his research examines the epidemiology and characteristics of firearm violence among urban youth and minority populations. One thing you'll notice as we go through here is we have a broad multidisciplinary team that really brings us perspectives across the field to have a full public health approach. Next, I'm simply thrilled to have Dr. Fred Rivera join us from the West Coast today. He's a professor of pediatrics at the University of Washington. He's worked in the area of violence and injury control and firearm injury, I will say, for 30 years, with many studies focused in the area of firearm prevention. He was instrumental in studies demonstrating the correlation between safe storage of firearms and lower rates of unintentional injury. He's published analysis among the barriers to safe storage counseling among healthcare providers and has evaluated both community and healthcare setting-based safe storage interventions. And then we will have up Dr. Zioli, who is an associate professor of criminal justice at Michigan State University. Her research focuses on the impact of state-level firearm laws on homicide and the implementation of these policies at the local level. She's primarily interested in firearm policies that restrict high-risk individuals from purchasing and the possession of guns, and those that facilitate the implementation of firearm restriction policies. Finally, I will introduce Dr. Bronis in case he arrives at the last minute here from his delayed flight, and otherwise we will have Mark Zimmerman present his slides, but he is a professor and chair of epidemiology at the Mailman School of Public Health at Columbia and has an extensive background in conducting research in an array of risk factors on firearm-related injuries among children at the individual and the community level. And much of his research has focused on place-based, spatially oriented risk factors for firearm carriage and use among children and youth populations. And with that, I welcome up to the podium Dr. Carter to give us our first overview. Thank you.
As Rebecca already said, firearm injuries for children and teens are currently the second leading cause of death when you combine suicides, homicides, and unintentional firearm injuries. When we compare children and teens to the adult population, we see some differences in the underlying mechanism. So among adults, suicides represent about 2/3 of firearm-related fatalities. But among children and teens, actually the ratio flips, and about 2/3 of fatalities due to firearms are due to homicides or firearm assaults. About a little less than 1/3 are due to suicide, and then about 5% are due to unintentional, or what's classically been termed accidental firearm injuries. If we look over time, we see, and we already saw in the graph that Rebecca presented, the decrease and decline in motor vehicle crash injuries going back to 1950s. This slide starts in the 1980s. The blue the blue line is the trend in motor vehicle crash fatalities, and the orange line is firearm-related fatalities. And you can see that we've had this steady decline in motor vehicle crash fatalities due to a lot of the scientific advancements that we talked about earlier. For the past 10 years, we really haven't made any progress in reducing firearm-related fatalities. And actually, our progress in motor vehicle crash fatalities has been so great that in about a little more than 12 states at this point, firearm-related fatalities have actually overtaken motor vehicle crash fatalities as a leading or a more prominent cause of death among children and teens. When we look at which populations are most at risk among children and teens, we see that older-aged adolescents really are the drivers of the underlying numbers of fatalities. And among that age group of 15 to 19, 1 out of every 5 deaths are due to firearm-related mortality. The reasons underlying firearm mortalities changes depending on the age group that we look at. Unintentional injuries, not surprisingly, are a much more prominent factor among younger-age children. And as we get into the adolescent population, we start to see suicide become a much greater factor. As with almost all injuries and at all ages across the spectrum, we see that male children are at higher risk than female children for firearm-related fatalities. And that increases substantially in the adolescent age group. You can't talk about firearm-related injuries without talking about the significant health disparities that exist, especially among racial and ethnic groups. Specifically, we see that there's a significant disparity with African-American populations and African-American children, driven largely by the significantly higher homicide rate that exists in adolescent African-American males. Outside of African-American adolescents, we see that a larger driver of trends is suicide-related firearm mortality, although in several of the age groups, it's actually achieving parity with homicide at this point. We often think about firearm violence as a primarily urban problem, but actually if you look at the data across the board, we see that it disproportionately affects both urban and rural settings, although the underlying mechanism and causes for that are different. In urban settings, it tends to be more related to firearm homicide, and the drivers among rural settings tend to be more firearm suicide and firearm unintentional injuries. The data that we see for, there's a somewhat lack of data on non-fatal firearm injuries across the board, but the data that we do have shows there are about 12,000 children, adolescents that are injured seriously enough every year by firearm injuries to require an emergency department visit. The majority of those occur among adolescent populations. The mechanisms of injury, again, differ with children under the age of 10 predominantly being affected by unintentional firearm injuries, and over the age of 10 predominantly assault-type firearm injuries. The smallest number of injuries that we see that come in as a non-fatal firearm injury are actually self-attempted suicide, and that's owing to the large case fatality rate that's associated with firearm suicide attempts. It's important to note that as much as 20% of firearm injuries among children who come in are actually injuries to the head, neck, or spinal cord, which have devastating impacts on long-term health. We see that one study that was done previously showed that 50% of those who get admitted to a trauma center after a firearm injury end up requiring long-term disability care afterwards and can't go home and perform their age-specific activities of daily living. School shootings tend to get a lot of press, and they're certainly devastating events and have been increasing in frequency. However, they represent the smallest proportion of pediatric firearm injuries that we see. Among those school shootings, about a third, a little less than a third, are due to suicide attempts. A little over 2/3 are due to homicide. And then there's a small proportion that involve both homicide and suicide. In about 70% of those cases, the firearm was acquired from their home or the home of a relative. And the majority of these are overwhelmingly due to handguns. Beyond the human cost that's associated with firearm injuries, there's a significant societal cost overall, both in terms of direct dollars that are borne by the healthcare system from treating both the acute and long-term costs associated with firearm injuries, about $8.6 billion overall, and the indirect cost to the US economy of treating patients long-term, of dealing with criminal justice issues, lost work and productivity, and lost quality of life. And the total overall cost is greater than the cost that we spend on treating obesity in this country, and it's around the same level as what we spend for Medicaid overall. So I've given you a lot of facts and figures. I want to sort of close by saying we need more data. That data drives knowledge about what works and what doesn't work, and that leads to action that we can disseminate throughout and implement throughout our communities at large. And we need that at every level of sort of the socio-ecological spectrum, at the individual level, at the community level, and at the policy level. And the next few speakers are going to kind of talk a little bit about ways that we can do that in healthcare, ways that we can do that in our communities, and ways that we can do that from a policy framework. And with that, I'll let Dr. Rivera talk.
Well, thanks very much for the chance to speak with you today. I think because I'm older than Rebecca, she asked me to speak somewhat about the historical aspects of this whole problem. And what I'd like to try to focus on a little bit is why or how did it come about that firearms came to be viewed as a public health problem? Really, for many years, it was really viewed as a criminal justice problem. I'm glad that April is going to be speaking from the criminal justice standpoint. But it really wasn't viewed necessarily as a health problem. It was certainly not as a public health problem, despite the number of deaths that happen to firearms each year in the United States. He's got to go get help. The first slide is a report that was published in 1966 by the National Academy of Sciences and National Research Council. And so accidental injury, a unsolved problem. And that report didn't say anything about firearms. Didn't say anything really about violence. It was really focused on motor vehicle injuries and particularly trauma care. This report was very instrumental in leading the United States to develop trauma systems. It led to the emergence of the EMS program and to the emergence of trauma centers and trauma systems. And sort of similar to what Rebecca showed before, I looked at 1950 to 1985. I found 177 articles on firearm injuries or guns in PubMed. And then if you look at 1985 to the present, 6,700 articles. And I put 1985 in there as kind of the watershed moment because it was the publication of the report Injury in America, a Continuing Public Health Problem. Many of you younger people probably don't know who Bill Foege is. Bill Foege was the former director of the Centers for Disease Control. It was probably the guy that spearheaded the whole move to eliminate smallpox in the world. He's an incredible guy. In this report, it was really the first time that people put together what we call unintentional injuries, or you might call accidents, and intentional injuries, the suicides and the homicides. And just pulled out a couple of quotes here from that. Assaultive injuries I'd regard as a crime problem rather than as a health problem. And then talking about suicide, and really the fact that really had been very little focused on the sort of physical and social environmental factors contributing to suicide, part of which are guns. And most of the focus had really been on the individual and the mental health problems. So I really put this in as a watershed moment in us begin to think about firearms as a public health problem. And that led directly to the creation in 1986 of the National the National Center for Injury Prevention and Control. This Injury in America report specifically suggested the creation of this. And it actually turns out, it's kind of a funny story. This was actually created with Department of Transportation money. So Bill Lehman was a congressman from Florida whose daughter had spinal surgery by Dr. Maya in DC. And Dr. Maya was very grateful to, Bill Lehman was very grateful to Dr. Maya for fixing his daughter. So, and I'm told this is a true story. So, Bill Lehman says, what could I do for you? And Dr. Maya was interested in neurotrauma, one of the first neurosurgeons really interested in neurotrauma. He says, well, we really need to have some funding for injury research. So Lehman took $10 million from the Department of Transportation budget and gave it to the CDC to start the National Center for Injury Prevention and Control. And that's how it started. When it started, it encompassed really both intentional and unintentional injuries. In 1986, they had issued their first funding opportunity announcement, and they first funded grants in 1987. They funded 5 injury research centers around the country, and they also funded grants, including on firearm research. I was really lucky to be associated with Arthur Kellerman, who at that time was an emergency medicine doctor in Memphis. He had been in Seattle. I had been in Memphis. We kind of switched, and he wrote a grant, and I was part of it, to look at the association between home ownership of guns or home access to guns and risk of violent death. This led to a series of publications in the New England Journal of Medicine, and Mark Rosenberg, who at that time was the director of the NCIPC, really talked a lot about firearms and the role of them in the public health. And this is kind of the sequence of publications in the New England Journal. John Sloan was a fellow funded by our Injury Center grant. He did these 2 studies comparing Seattle to Vancouver, British Columbia. They're very similar cities, separated by 140 miles, but live on different sides of the border. And so in Vancouver, there are pretty strict rules about ownership of guns, particularly handguns. In Seattle, state of Washington, very little rules at that time. And it showed that in Vancouver and Seattle, there are higher firearm homicides and suicide rates, and overall higher homicide rates, really all due to that difference between gun and non-gun homicides. And then in 1992, we published the first part of the case control studies with Kellerman on suicide in the home in relation to gun ownership. In 93, gun ownership and the risk of homicides in the home. In 1996, we did a study on injuries to firearms in 3 cities, Cleveland, Memphis, and Seattle. Well, it created some backlash. It created a big backlash. In 1989, the NRA, in their American Rifleman magazine, carried a story about the Sloan, Vancouver, Seattle papers and called on members to write the Assistant Secretary for Health about use of tax dollars to conduct anti-gun pseudoscientific studies disguised as research, published in the New England Journal of Medicine. And then in 1991, the NRA asked the Public Health Service Office of Scientific Integrity Research to conduct an evaluation of the integrity and the competency of firearms research funded by the CDC. That's a big deal. If you are found to be guilty of this, your career as a researcher is pretty much done. NIH refused to look at the case. In 1995, then after that 1993 publication of the homicide and home ownership of guns, 10 senators expressed concern about, quotes, duplicative nature of the CDC research, saying that this was being done by the National Institute of Justice and other organizations, and also about the NCIPC's promotion of a political agenda. They threatened to eliminate funding for the entire NCIPC program. But what they ended up doing was they cut the budget by $2.4 million, which was the exact amount was being spent on firearm research. And then in 1996, the Dickey Amendment was passed. I'm sure you've heard of the Dickey Amendment. It was Congressman Jay Dickey, who was the originator of this amendment. And it actually didn't forbid the CDC from conducting gun research. It just said that no federal dollars could be used for lobbying for gun control. Well, no federal dollars can be used for lobbying for anything. But the way that the congressional intent is that the CDC should not fund any more firearm research. And here we are 22 years later, and that still is in effect. The CDC has not funded any firearm research since before 1996. You might ask, well, the CDC has a budget of, I don't know, I think it's $11 billion a year. NCIPC has a budget of a couple $100 million. So why can't they switch, move $10 million from this pot to put into that pot? And I was with one of the former directors of the NCIPC last week, and she told me that they weren't allowed to speak about guns at all in the building when she was director of the NCIPC, and that the director was worried that Congress would take retribution on the CDC if they did any internal shifting of money. So the end result was they didn't fund any firearm research and still haven't. Interestingly, somehow I came across this. You're all familiar with the ACA. That on page 766, there's a Second Amendment clause put in there by Harry Reid, a Democrat. And it was basically saying that no information about gun ownership can be retained and collected in the medical record. And nobody can be forced to talk about guns if they don't want to. But it's in the ACA. So given that background and bringing us to today, where are we? Well, first of all, I think that for health providers, it's really important that we screen for firearm ownership and storage practices. We live in a country where there are 300 million guns and a Second Amendment. We're not going to get rid of guns. We shouldn't talk about gun control. But we need to talk about how can we prevent injuries, particularly to kids, the subject of the forum today. Florida passed a law that basically forbid physicians from asking about guns with their patients. They're forbidden from asking their patients whether they had a gun in the home. That went back and forth for many years in the Court of Appeals, and finally, in February of 2017, the 11th Circuit U.S. Court of Appeals threw it out on the basis that it violated the physician's First Amendment rights. I think that we really need to work to restrict access to firearms by those who might use guns to harm themselves or others. Let me give you a few examples. Depressed patients, patients with suicidal ideation or attempts. I think we all would agree that those individuals shouldn't have access to guns. We have a number of emergency medicine docs in the first two rows here, and I guess I would challenge what is being done in emergency departments around the country in terms of appropriately assessing suicidal patients who come into the ED, and what interventions are made if people do admit that they have access to lethal means to get rid of those lethal means before they leave the emergency department. Domestic violence protection orders. So we did a study a number of years ago that showed that domestic violence protection orders are probably the single most effective thing to prevent repeat abuse of a woman in a domestic violence situation. In our state, there is a checkbox that the women, when they file for a protection order, can check off whether or not the assailant has a gun or not. Now, the assailant, if she does check that off and the protection order is granted, the assailant is supposed to voluntarily give up their guns. In King County, in 2017, King County, Washington, where Seattle is, out of something like 150 protection orders, there were only like 15 times was the gun actually voluntarily taken in. And there really aren't any police going out to get the guns. So again, I think that comes back to us as health providers is, are we counseling victims of intimate partner violence to get a protection order? And to make sure if that protection order is issued, that the gun is removed. And then there's the extreme risk protection order. Washington is one of, I think, 6 states that have this, where a family can go to a judge and say, my loved one has a gun, and I'm really worried he's going to use it to harm himself or others. So that creates an extreme risk, and the judge can then grant that the person should have the gun taken away. It's a temporary, it's not a permanent. You would think that with physicians, ER docs, people in private practice, psychiatrists would make great use of that. Again, in the state of Washington, in a period of about a year, it's only been used about 65 times, and the vast majority of those were at the insistence of the police, not medical providers. So again, I think that's a failure on our collective part. And then I think we have to become informed. I think nothing's going to happen at the federal level in terms of legislation, but there's a lot of action at the state level. In our own state, we have an initiative, 1639 is coming up in a couple of weeks, which would change a number of the laws related to guns. In the state of Washington, you have to be 21 to buy a handgun, but only 18 to buy an AR-15. And so one of the parts of that bill is to change that. And I finally want to end up with this slide here, which was published in JAMA a couple of months ago, this article. And I think points out how the US is such a big part of the problem. You can see that it's about 250,000 people died from firearms globally in 2016. 6 countries account for 50% of the deaths. 2 countries, Brazil and the US, account for a third of the deaths. Each year since 1990, the number of civilian firearm deaths have exceeded the number of firearm deaths in conflicts. The only year that was not true was 1994 with the Rwanda genocide. Each year there are more civilian firearm deaths than deaths in conflicts. God knows we in this world have a lot of conflicts going on. And the rates of firearm deaths range from, you can see 0.1 per 100,000 in Singapore, basically, like 1, to 39 per 100,000 in El Salvador. And what's I think is really startling, and the fact that's often forgotten, is that firearm suicides are really a big part of the problem. 35% of all firearm suicides in the world occur in the United States. So I think we have our work set out for us, but I really am hopeful that we are at the threshold of making a big difference. Thank you.
So I'm going to talk to you about what we know about current firearm safety policies and child outcomes, and a lot of what we don't know about current firearm policies and child outcomes. Now, gun policy research is mainly conducted at the state level. There are a lot of variations in state laws. There's variations between states in what laws they have and when they enact those laws. And gun violence policy researchers are able to take advantage of those variations to test for associations with outcomes. Now, those research studies are commonly conducted with the entire population of the state. So how many homicides are in a state year, how many gun suicides are in a state year. And very few actually look at pediatric populations. Those studies that have looked at pediatric populations in specific tend to be studies of firearm policies that are specific to children. So child access prevention, or CAP laws, and minimum age laws. And when we think about ecological studies, these ecological level studies, they're limited. Our ability to make causal inferences is quite limited. So when we can point to a law and say, this law is intended to affect this specific population in this way, and then test that specific population for that outcome, then we have a kind of a stronger argument to make when we interpret any associations that we find. Consequently, we're not testing these broader firearm policies on our child outcomes. And as we heard earlier, children are not just tinier adults. And the results may differ when looking at entire populations versus looking specifically at our pediatric population. So gaps in our knowledge abound. So child access prevention policies. It's funny giving this presentation in front of Fred Rivera, who's done much more of this particular research than I, but CAP laws vary from state to state. In general, CAP laws are those laws that allow prosecutors to bring criminal charges against people who somehow allow children to potentially or actually gain access to guns. Now, criminal liability in some states is only for reckless provision of a gun to a child, somebody under the age of 14 in some states, under the age of 18 in other states. In some states, that criminal liability is extended to negligent storage. And this is, depending on the state, whether the child could gain access to the gun. In other states, it's whether the child does gain access to the gun. And further, a child may need to carry or use the gun for this criminal liability for these criminal charges to be brought. And these criminal charges can be felony or misdemeanor criminal charges, depending on the state. So there are some really rigorous research studies, state-level interrupted time series designs that have looked at unintentional firearm deaths among children and firearm suicides among children in association with these CAP laws. And we do see a 17 to 23% reduction in unintentional firearm deaths in those under the age of 15. This might be driven by those states that allow felony charges to be brought against people who negligently or recklessly allow their children to have guns. When you remove the states that have felony charges, Florida in particular, associations sometimes drop out. There's an 8% reduction, one study found, in suicide in 14 to 17-year-olds when CAP laws are present, and decreases in firearm suicide. Most of these studies don't look at non-fatal firearm injuries. There is some evidence to suggest that non-fatal firearm injuries do decrease when CAP laws are present, and those associations might be stronger when the state when you incur criminal liability for negligent storage than whether the state only criminalizes reckless provision of a gun to a child. But the research here is pretty scant and not terribly rigorous. Associations with interpersonal firearm violence are understudied. We don't have a lot of information about interpersonal firearm violence injury or death. We also don't know how CAP laws are implemented. It's unclear how the law is communicated to gun owners. Some states do require there to be some notification, a sign in a licensed gun dealer's store that informs the gun buyer of the CAP law, of the criminal liability. One study did test to see whether that made an impact. They found no association with that in firearm outcomes. And we're in Michigan. Many of you are from Michigan. How many of you knew that Michigan just passed a child access prevention law? Yep. Not communicated well. It's been around for about a year, and it's very specific to school shootings, in fact. You will only incur the misdemeanor criminal liability if your child violates a state firearm law on school grounds or in a school vehicle. So Florida actually did a large PR campaign when they rolled out their CAP law, which again had the felony criminal liability. And again, Florida is one of the states driving these results on decreases in unintentional deaths. So might the PR campaign have something to do with this? Might it be the felony charge? Could be a combination of both. We need more research to decipher these results. We also don't know how often charges are actually brought under CAP laws and under what circumstances charges are brought. And we don't know if that might even make a difference in the impact of the CAP laws or if it's simply a culture change that is happening due to these CAP laws. Minimum age laws. So this is the second type of firearm law that is focused on children. There was one study of the federal minimum age of possession at age 18, and it was associated with reductions in firearm suicide and unintentional death. There have been a couple of studies that looked at state minimum age laws, age 18 or age 21 for purchase or possession, And none of those studies found any association with the fatal firearm violence outcomes, homicide, suicide, or unintentional death. Some other laws have been studied as well. Background checks, there are 2 studies. One looked at a comprehensive and automated background check system and looked for associations with unintentional firearm fatalities. The other looked at permit to purchase laws and whether there was an association with firearm suicides. Neither found any association. I should say the permit to purchase study had very limited ability to find an association because there was only one state that changed its law during that study time, and it was a pretty small state, Connecticut. Domestic violence, misdemeanor firearm restriction laws. Domestic violence, it wasn't mentioned earlier, but 31% of children under the age of 13 who are killed with a firearm are killed in relation to a domestic violence event. So domestic violence is one of those places where we really might make a difference with our domestic violence restraining order firearm restrictions. None of those have been tested on these pediatric populations. One study did look at the federal domestic violence misdemeanor firearm restriction, and it did find that there was a reduction in homicide for familial children and separately for familial male children. However, this state used a relational definition for children, and there were no age bounds. So while as an intimate partner homicide expert, I can tell you that most of these children were probably under the age of 18. This study doesn't give us that information. It doesn't give us any of the descriptive statistics we would need to really look at that. And stand your ground laws, those laws that remove a duty to retreat in public spaces and allow you to use potentially fatal force in the face of threat, have been associated with increased risks of hospitalization for firearm injuries for children who live in stand your ground law states. What don't we know? We don't know an awful lot. As we saw, when children are killed when they're dying in firearm events, this is homicide. This is mainly homicide. Very few unintentional, much smaller percentage, at least unintentional, smaller percentage suicide. Homicide is the main share of fatal firearm injuries. Homicide could occur by someone in your under 18 age group hurting you with a firearm, but it could also be somebody over the age of 18. So firearm laws that focus specifically on those under the age of 18 and preventing them from getting firearms may not be expected to do a whole lot to save our under 18 age group, our pediatric age group, from firearm homicide. It might be that those laws that are broader, that target adults in particular, we might see a greater benefit in lives saved. Now, one of the laws that people have been talking about a lot lately are those gun violence restraining orders. They're also called red flag laws or extreme risk protection orders. Those laws that allow law enforcement, that allow a judge to have a gun removed from somebody who is in danger to themselves or a danger to others. And those are talked a lot right now in terms of potentially addressing school shootings and mass shootings if somebody gives signals that they are dangerous. We need research to determine whether or not these gun violence restraining orders do have an impact on those types of shootings or shootings in general. Certainly if they're not going to be used, we wouldn't expect to see any effect. But more broadly, these laws that restrict high-risk individuals, domestic violence perpetrators, people with alcohol addictions in crisis, other people who are suicidal. If we looked at those laws restricting those individuals from firearm access, we might find that they affect our pediatric population. We need to do the research to find out. And then those anti-gun trafficking policies, may also be associated with pediatric firearm injuries. They are understudied in general, but certainly understudied in this population. Again, when guns are in the hands of people under 18, handguns at least, it's illegal. Those are illegal firearms. When restricted people have access to them, it's illegal. So if we focus on moving or preventing the movement of guns from the legal market to the illicit market, we might affect pediatric firearm injuries. But we need studies to discover whether these one gun a month policies, straw purchase laws, more background checks, permit to purchase, whether any of these policies actually do affect our pediatric populations. And we need these studies because our legislators look at a ton of gun bills every single year. And right now, they don't have a lot of evidence to consult when they look at these bills and decide whether or not to vote on them. And we would like our legislators to have research evidence to bring to bear on these issues that affect our lives and our children's lives. Thank you.
I'm Charlie Brannis. I'm with Columbia. I'm very pleased to be here, even though it's a very last minute. I want to talk to you today about a new line of, relatively new line of research and thinking about preventing gun violence in the U.S. and abroad. And it's really thinking about our surroundings and the importance of our surroundings. And we've always, in epidemiology and public health, we're always taught about the relationship of people, pathogens, and places. And this comes into play for things like malaria or dengue in terms of the host, the agent vector in the environment. Here it's a mosquito in a swampy forest. And this is a favorite quote of mine that if a brackish tidal pool is breeding mosquitoes, filling it in may be far more likely to reduce malaria for years to come and long after the funding has run out than expecting the local community to continue applying larvicide. I think the same idea can apply to gun violence. Yeah, and so the focus here is so this is a mirror situation with firearms, which is a host, agent, vector, and environment. And I think we've spent a lot of time focusing on the host, the people, and the firearms themselves. And I think we've spent less time focusing on the context that seems to be producing the gun violence in the first place. And we began to think, and then people here at the University of Michigan also were thinking at the exact same time, very similar ideas about what if we began to address those surrounding contexts, the places. And one of the reasons that sort of drove me into this, I had a couple of thoughts. One was there was some work emerging out of the medical system that was having some great impact, but the impact was short-lived. And this is a similar, sort of an analogous situation with police presence. This is work that was done a few years ago that this is police patrols. And when there are police patrols, we think that there's a decent reduction, especially targeted police patrols in crime or violence in that space. But once the police patrols are lifted out of the space, it's pretty limited. The crime will return, and in fact, perhaps the gun violence will return. So this leads us to think a little bit more about what got me into this too, and perhaps in the year 2000, when I was working, interacting with a guy named Len Syme at the University of California, Berkeley. And he began letting me think about these things, the difference between a high-risk program, which has all these advantages, programs that focus on high-risk individuals. For instance, individuals who are high risk or susceptible are often particularly motivated to be acted upon to reduce their risk, and these programs are actually quite cost-effective. But they have many disadvantages. There's difficulties and costs to screening. The idea of profiling comes into mind here. They're often palliative. That means they're only addressing the immediate issue at hand and often temporary. So the returns on these can be fleeting. And in fact, vulnerable individuals, those at risk, continue to cycle into the system. This is one of the things that Len kept on reinforcing with me. And even if you get folks to begin to be healthier or to begin to think about not acting violently, their actions may be continually thwarted by the context within which they are in, if that is a particularly challenging and chaotic context. Now, population programs, on the other hand, and I'm invoking Jeffrey Rose. How many of you know the work by Jeffrey Rose in 2001 and before then? Okay, so population-based programs have a number of advantages over these high-risk programs. One is that they're radical, that they're doing something completely new oftentimes, and that they're long-term. So the return on these can sometimes, if they're done correctly, can be sustained. They confront root causes, and they do things like make the healthy choice the easy choice. That is, they can be default-type programs. They may ask little to nothing of those who are going to benefit from them. And they may indeed, in the end, establish new norms and allow us to stop trying to re-persuade individuals over and over again to change their behavior. The disadvantage is that there are small benefits to any given individual. So if you ask someone, did this program help you, they are often not able to tell you that it did, specifically for them. There are few grateful patients, so there aren't as many stories to be told here, so the programs, it's difficult. And frankly, the radical side of these is a disadvantage. So it's very difficult to change thinking and move away from high-risk populations, but from high-risk programs to population-based programs. But I'm going to quote Len and say that these programs that focus on things like places, which I want to talk about just a little bit here, and structural dimensions can actually influence the lives of more people and for longer periods of time than these individually based programs. With that in mind, our group has been really thinking about what we call in situ programs. That is, programs that are designed to change the very context that people live in on a day-to-day, live in, go to school, go to work, and so forth. These are programs that are not designed to relocate individuals. Rather, they are designed to make structural changes to local environments in a simple, often inexpensive way so that it's scalable to multiple neighborhoods or environments and multiple cities, and that these can be sustained for extended periods of time. I'm going to show you a few of these that we've looked at for gun violence. One is a vacant lot greening program, which is akin to what's being done here through the University of Michigan and in a number of other cities. And another is an abandoned building program. And what we find is that when you alter these spaces with some pretty simple fixes, gun violence goes down. Now, this is early quasi-experimental and observational work. Gun violence goes down, we found, from anywhere from 5 to 39%. And even with the small return, the cost of gun violence is incredibly high relative to the low cost of these programs. So that for every dollar in, it can produce anywhere from 25 to hundreds of dollars in return. We've recently published results from an experiment and a randomized controlled trial on the vacant lot portion of those. We are working on one for the abandoned building that's active in treatment right now. And this program has shown a number of things that have been significant, including gun assaults and shootings. Now, I will say that, and I will say that for the gun assaults, I made that red. So gun assaults are when anyone threatens someone with a firearm, whether they're shot or not. Shootings are when someone's actually injured. And so when you account for, there's a number of different outcomes here in this trial, when you account for the correlation between them and the multiple testing adjustments, gun assaults, which are on the borderline, actually probably are not statistically significant anymore, so I need to say that. But all these remaining outcomes of, if you add up all the crimes, the shootings themselves, that is when people are actually injured with a firearm, burglaries and nuisances, all remain statistically significant even after accounting for multiple testing. And then I'll also say, when you take a look at not only the neighborhoods, so this was across the city of Philadelphia, this for all neighborhoods, and it was randomly selected, but when you account for neighborhoods that are only below the poverty line in the study, and we had a more than sufficient number of them to do this analysis, these numbers actually get even more significant. And you can see, again, in this case, all crimes, burglary, and nuisances, but the gun assaults actually are quite significant here in this analysis. So in the end, we think that this is a bit of what I'm going to call win-win science. That is, we're generating this great new knowledge, right? That's good science and can be moved on to other spaces around the country. But it's also a win for those communities when you raise the money and bring in NIH dollars, for instance, to actually make some changes in those communities. And so the significant results I was just telling you about in terms of nuisance crimes and firearm assaults, we also had a whole series of different field interviews that were done, and I have to call these preliminary, but they are co-benefits that we're finding that are statistically significant. Things like people, we think, are going outside more. People are relaxing outside more after this greening is done. People are actually reporting that there's less nuisance vandalism and crime in their spaces, which is a nice mirror to the actual police reported outcomes, right? So people, not only the police finding it, but the people are experiencing it as well. And then a study that we recently published looking at one particular finding on mental health, people are reporting in particular less depression after the treatment is done. So there's a number of co-benefits that may accompany the actual police-reported outcomes in this. And the final thing I'll say is that this sort of place-based work has been, there are a number of cities that are beginning to do this kind of work, or that have done this kind of work. I have to credit Francis Kuo and Bill Sullivan in Chicago for doing some of the earliest version of this in the Chicago affordable housing, where they looked at tree canopy in there and vegetation, and you can see that's the black and white of some of the earliest work that comparing affordable housing developments that had a lot of vegetation and those that did not. And there was 56% fewer violent crimes in those that had vegetation. I'm showing you our result. I'm reporting the new, I think 2018, right? This paper just came out for Flint, where there's 40% fewer assaults and violent crimes, and this is a greening program. New York City has just published some work on lighting and the importance of public lighting and how that might be reducing in a trial format, might be reducing assaults and weapons crimes. In Youngstown, although I don't have the number there, we did do a study, rather than me putting the regression coefficient up there, it's not a percentage, but there were significantly fewer results. In New Orleans, we just published something recently where there were 6% fewer drug crimes, although I have to say, in New Orleans, we're finding that there were not fewer violent crimes. And then there is a study that also just came out in New Haven that did not find significant results. So it's important to get the balance of all the different literature on this. And it's 5 o'clock. That was my 10 minutes. I'm just going to leave you with a picture of one of our green spaces in the city of Philadelphia that I snapped only a couple weeks ago. Thank you.
I'm Mark Zimmerman. I'm also involved with FACS. I'm a professor here in the School of Public Health, and I've been charged with leading moderating the questions. And I have a few canned questions, a couple of rules. One, we have to be out of here at a very sharp 5:15 because there's another group coming in. So I'm going to make sure that we get all that in. Number two is if you have a question, there is somebody who will have a microphone to hand to you. Because this is being both recorded and streamed, we need you to speak in the microphone so other people can hear it. That goes for you guys too. When you answer a question, please speak into the microphone, okay? So, having said all that, are there any questions? I have a couple of canned questions if there are none, but I hope some folks might have any questions for anybody. Yes. Microphone is on its way.
What would be a good way for the individual to get involved in sort of a place-based renovation or like adding vegetation or lighting or something like that? How can that be done on an individual level?
Do you mean you as someone in a university or a local community member, or either?
Both, yeah.
So I think one of the great opportunities, and the way we learned about the programs we're studying, is because someone in the community said, hey, you know, we just decided to do one of these, to green a lot, to make a pocket park, to plant some trees, to install our own lighting, and we think it's making a difference. And I think identifying a lot of those programs and bringing them to light would be helpful to the scientific community. But I think, on the other hand, if there's good science behind some of this, perhaps transitioning into more of an advocacy role that maybe some of the scientific community is less inclined to do would be very helpful.
I'll also add, if you're here at the University of Michigan, Allison, can you just raise your hand? Contact Allison Rosinski. We could probably get you hooked up either in Flint, or if you're from Ohio, we could connect you up in Youngstown, Ohio. There are places and opportunities if you want to do this as personally for yourself. Anybody else? Any other questions? Yeah.
I have a couple of questions. My first question is for Dr. Brannis. In your studies, when you were looking at community members and asking them how the impact on their mental health and those other questions, how did you measure those questions, and how did you ask them if you were doing a survey?
Yeah, so we had, it was a now 5-wave survey where folks were randomly, so I have to say the lots that were treated were randomly chosen across the city, and then they were randomly assigned to the 3 different groups. Within the clusters, little quarter-mile clusters that each group of lots was in, we then walked around and found 4 people, 4 or 5, to interview over 4 or 5 waves.
Okay.
And for the mental health, it was a Kessler 6 scale. So it was a standardized scale that was used. I mean, it is a screener, so it's not as if we brought folks into the clinics to determine, to do a full mental health workup on them.
Okay.
So it's preliminary information, but it's an important first step in showing, I think, that perhaps this kind of exposure to green space, new green space, may have an effect on mental health.
Okay. And then my second question is, as a soon-to-be pediatrician, what are some ways that I can start to get involved or kind of advocate for my patients in the coming years?
There are a number of things I think you can do. First of all, I think incorporating routinely asking about guns in the home as an important part of your regular well-child visits, particularly if you're seeing adolescents. I think it's an important question. The other thing is that at our hospital, after we had a school shooting, our senior vice president who lost a niece in that shooting, we started a gun lock giveaway program. And our hospital has events around the state. They're usually held in sporting goods stores that sell guns. But we give away gun lock boxes or trigger locks, and we give away 400 or 500 of these things at a shot. People line up for about 3 or 4 hours before the event to get these things. And we've done some surveys then, calling these people about 2 to 4 weeks afterwards and finding out that they, in fact, are using these devices. So I think that's another way for you as a prominent member of your community can really have an effect.
Thank you.
Anybody else? We have 10 minutes behind you. Thanks.
Yeah, I'm wondering if the public health threat kind of angle has been kind of given up. Has the battle for, and the phrase gun control seems to be such a buzzword that perhaps it needs to be replaced with a less, more neutral kind of affective phrase to it. But it just seems to me that background checks and licensing and the illegal gun area it's kind of been set aside by the groups that are trying to get a sane kind of answer to our problem here in America, and I'm wondering your impressions on it.
I'll spot, and then I'm sure my other panelists will want to say something. I mean, I think that we really don't use word gun control anymore. I think for a lot of reasons. First of all, what does it mean? Secondly, it is a kind of a hot trigger phrase. I think that we really focus more on the whole issue of recognizing that firearms are a large health problem, a large public health problem, and how might we be able to reduce that by figuring out how to reduce access to guns by people who are going to harm themselves or others. So I think that's really where a lot of the legislation is, where a lot of the education is, a lot of the work has been done. And it's all, I think, being done in terms of legislation is at the state level or even smaller city level, not at the federal level.
Yeah, I was going to say, April.
Yeah, and I would add that in scientific, surveys, opinion polls, when you do use phrases like, restricting access to dangerous individuals, as opposed to things like gun control and removing access to guns, you actually find that there's quite a lot of agreement among Americans on provisions that might be passed into law. There's quite a lot of agreement that domestic violence offenders shouldn't have access to guns. Taking the loaded wording out of these questions, does a lot to bring people together and realize that we're talking about the same thing. We're just using different words.
Was that a pun? Loaded terms? Never
I know,
mind.
he used trigger too. We can't get away from it.
I know, we can't get away from it. Impact and stuff. So
Just one quick last, on the statistics for the reduction in violence in the cities, was that geared to the whole city, or was that specific to the neighborhoods that were greened and renovated and so forth? Was it
So
40
that was percentages. It was for the neighborhoods that were greened, although
Just
they
the-
were citywide. So there were, I can't remember, 80 clusters or something like that citywide. So they spread across the city. Unfortunately, the vacant spaces, though, are more concentrated in the most impoverished parts of the city. So that's the representation you're getting.
One of the reasons for that could be that that's where also the most need of greening might need to happen. So there's less of a ceiling effect potentially, right? I mean, that's one explanation for that. There are obviously lots of others. Any other questions? Wow, you don't count. You're one of us. No, go ahead, and then we'll go up there. Go ahead. Microphone.
Yeah, I'm just curious with the whole greening stuff. Has there been any city that has taken that up alone outside of the research environment to say, hey, because there's a lot of evidence now that's been building that it works, but do people say they're going to do it politically? And what is their associated cost with a city saying, okay, I want to green up my blighted areas?
I think there are many cities that have taken a focused interest on it. So it's been interesting that the group we worked with in Philadelphia, the Pennsylvania Horticultural Society, is connected up with Keep America Beautiful. And KAB has been a conduit to cities across the U.S. Now, really, only a handful have then transitioned to really put it into action. For instance, the work that we did that we're starting, I shouldn't even say that we're doing, right? So this is Tulane University that's leading this work along with the city of New Orleans, but that came out of work that we were doing, that the University of Michigan was doing, that they noticed and wanted to put forward. Columbus, Ohio is another good example of a city that's going to be launching some of this. Milwaukee is another good example of a city. Now, many cities do have these programs in general, programs that will deal with blight remediation, as it's often a blight ordinance. But they haven't been as, I guess, institutionalized over the long term as they could be.
A couple of other things just relating to that. One is I think Detroit just got $100 million to do this very work. I don't know who funded it, but I think it was a local foundation. I think it was the Wilson Foundation did that so yeah, this is happening big time. Not all states have a land grant law, which allows the states to take over abandoned properties, and there's laws about how long it has to be abandoned and whatnot. But more and more states are getting into the game, and more cities are starting to do that kind of work. So just to add on to what Charlie was saying, there's a question back there. We have like basically 2 minutes, so talk quick. Answerers, panelists.
So,
Go.
like with laws like the extreme risk protection orders, how are those laws kind of like that information like disseminated to like interested parties? And what are like some of your recommendations to like let like CAPS laws or whatever like get to the interested parties like effectively?
In 1 minute or less. Okay. So the gun violence restraining orders, we don't know how states are communicating that gun violence restraining orders exist to those who might petition for them. And it differs from state to state on who can petition for them. In some states, only law enforcement can, or people in the criminal justice system. In some states, family members can. In Maryland, I think it's the only state that mental health professionals can. So how they're finding out, I'd love to know. Particularly law enforcement. Can they get the message about CAP laws and gun violence restraining orders out better? Certainly, we might look to see how Florida did it with their CAP law, but I don't know that I have time to go into much more.
You have 2 minutes. Go ahead.
Oh, I do.
It was 5:13, and we have a 5:15. And by the way, at 5:15, everybody has to run. Okay, run outside to the reception, which is down the other end of the. It's going to be right out front. The reception right here. So continuing the conversation, but go ahead, take another minute.
Okay. So, so with these gun violence prevention orders, we know that California, their law passed a couple of years ago, and you know, they haven't seen a whole lot of movement. We just heard it was Washington, you know, that hasn't seen a whole lot of people getting gun violence restraining orders. Oregon seems to be on the right track for people petitioning for gun violence restraining orders. I don't know yet whether that's law enforcement or family members or how that is working. But with gun violence restraining orders, there are a couple of mass shootings that we in particular think might have been prevented had this been a tool that law enforcement was able to use. So certainly the message does need to get out.
Having said that, it's a beginning of changing a culture. When we first passed seatbelt laws, not everybody was wearing them, but today, kids don't get into a car without buckling a seatbelt without even thinking about it. So maybe, even though they're not being implemented right now, at least it's starting to crack the door open to allow us to, you know, maybe have more campaigns about it and make people more aware of what's going on so that they can be more used. Some of them, the fingers crossed on that for sure. Okay, it's 5:15, everybody. Thank you so much for attending.